So this eye has a few unique combinations. A moderately shallow anterior chamber. There's been a previous peripheral iridotomy that's not visible. Besides that, there's some keratoconus. And finally, the patient is on Flomax. So we're going to make a side port opening here. And of course, on all shallowish chambers, we want to be careful that we don't strike the lens on the way in. So we go in a little shallow and wiggle to enter slowly. Now what about that pupil diameter? Going to feel a little sting for a few seconds. Is it big enough? A little stinging. Well, it depends on the technique you use. And a lot of times in these Flomax eyes, the pupil enlarges with the viscode injection, as it just did here. Now if it stays that size, well, that'd be just fine. But it might not. Why might it not stay that size? It might not stay that size if we remove the OVD. And namely the dispersive OVD that we have at the pupillary margin. Because that's what's holding the pupil in a somewhat dilated configuration. Now, if this were 3D, you could see the convexity of the anterior capsule. And those are the ones that tend to run out into the periphery. So we'll watch it carefully as we come around. You know, we want a rexus it's large enough to, what's cornea please? Permit us to successfully remove the cataract. And that'd be big enough. It's not a big rexus, but it's big enough. So next is hydrodissection. And I didn't even get all the way across, and the chamber was pretty shallow, so I just depressed the nucleus a little, came to the other side, did it there. And now we'll do a little viscodissection. So phaco in the moderately shallow chambered eye. First, we don't really want to use any ultrasound near the endothelium for obvious reasons. So how do you reduce ultrasound applications near the endothelium? That sleeve wasn't on correctly. Notice how I just adjusted it here and repositioned it. Now I'm turning it to get good infusion flow. So we're going to aspirate a lot of this lens. So this is just INA. No need to rush to do ultrasound here in the anterior layers. Then I'll put the chopper out over the equator. And only when I have the phaco tip buried in the nucleus did I use ultrasound. And now I'm pointed away from the endothelium. So I got a nice deep bowl there. Pupil is behaving fair. Keep an eye on that. So there's our first chop. Now there's epinephrine in the infusion bottle, and if that's not adequate, to maintain the pupil, then we would have to consider iris retractors or something like that. But thus far, we're okay. Wet the cornea, please. So I'd really prefer to get the nucleus divided before I remove segments. And let's go to epinucleus.
What? Epinucleus.
So here you want to be careful working near this flaccid iris. And I might just go in and put some more viscode in here in a second. So I'm staying in the middle of this pupil. And I'm using somewhat lower flow rate than I might normally use, because of the flaccidity of the iris. And I just don't want to be aspirating near the iris. Wet the cornea. And we got some epinucleus left here. A little bit of nucleus. And I think soon we'll go to INA. Yeah, I think we'll go to INA now. So, if I just come out with high infusion pressure, the iris will follow. So I'm on position 0, and I'm literally decompressing the globe here before I slide the instruments out. So let's see what happens to the pupil when we go in with INA. Might it get a little bit bigger for us? And spatula. No question where the side port plate is. That's where the iris wants to come up. Side port opening. And we're getting down to subincisional, a little bit off to my right there. And now if we look for a crypt, we can push the iris out so we could see the cortex better. And that looks pretty good. Quick look around. Okay, same principle. Lower IOP. Position 0. Come out. Syringe BSS. So before we put an IOL in here, this keratoconic eye, we're going to do a couple of things. We're going to take an aura reading. Notice, the tendency of the iris to prolapse here is pretty significant. See if we can trick it into staying in there. A little bit of fluid flow. And IOP is normal and still there's that tendency. So I'm going to take a spatula and I'll sweep that iris central in an eye with a low IOP. Yeah, something like this. So now I have the side port. And let's see if we can't do this through the side port, because if I do that through the primary incision. Okay, so now the iris is free, and let's see if we can just deepen the chamber. Little aliquots, how you want to do this. If you do a sudden injection, increase the pressure in the eye. and have any egress, you know what'll come out. We're approaching normal IOP and time for us to do an aura reading. So we'll take a quick reading of IOP. That's about right. So yesterday the pupil was too small. We could not get an aura reading. This morning we've done an aphakic refraction. This is the following day. And we're going to now try to get another aura reading. So our aura has done and is indicating that we need a 24.5 diopter lens for our target refraction of minus 50. And that's exactly what our aphakic refraction indicated. And from the aphakic refraction, we have calculated the toric axis and power. So we'll put in our toric IOL. And it's going to be a T4 lens. And the axis is 80 degrees. So of interest, many patients, when they're sleeping, or they're just the way they breathe, they'll have a head bobbing motion. And he does. And you can see it's significant. If you were doing something very fine, it could be a problem. So I'll just show you what happens. If you push on the top of the patient's head on the forehead, hold it down, you can't eliminate it, but you can reduce it by about half. Now, frankly, I don't have to do anything here because I'm just putting in the IOL. But I would have the technician put his or her hand on the forehead and press straight down if I needed to reduce those excursions of the head. And now I'm going to let go and we'll see the head move more. So we're back to the original length of excursions. Okay. So let's put in our IOL. I got to find our little side port from yesterday. Wet the cornea, please. Good. And this is our toric T4 lens. Now in a small pupil, it can be a little tricky to see the periphery of the lens and the little dots on it. Make sure you line it up right. Remember, yesterday we used the crypt to see his peripheral cortex. We can still use the crypts to see the location of the dots. So right now I'm going to leave the lens about 20-30 degrees shy of the final resting spot that I want. And then we'll remove the OVD from behind, but not in front of the IOL. Why not in front? Remember, this is Flomax and a floppy iris. Now, if I leave the OVD in front, there's less of a chance for the iris to prolapse, but I'm still going to let the IOP go to 0. My next step will be to seal the phaco incision while I still have a nice behaving iris there. So the sequence in which you do things really counts in these, call them complex situations. And just making sure this is sealed. Okay, so my next step is going to be to take a spatula and position the IOL at the desired axis through the side port. In the chamber, it'll shallow some, but it won't flatten because I still have OVD in it. Getting close. Okay, now let's deepen the chamber and center the lens. We'll do that through the side port here. Still leaving some OVD in the anterior chamber. And let's see, yep, that looks good. We're parallel to those marks. I like it. Okay, so the last thing I'm going to do here is to irrigate that OVD out of the anterior chamber. Interesting little fragment that momentarily went behind the IOL and then came back, behaving nicely for us, so I didn't have to go back there and irrigate it. So there we have a keratoconic eye, Flomax, smallish pupil, or aphakic refraction, toric IOL, and we're done.